Hey there, my name is Jonathan Friedman, and you're listening to 5 FAQs by EHN Canada. This is the show where we scour the internet for the most frequently asked questions about mental health and addictions and ask an expert for their answers to them. Today, it is my pleasure to introduce our guest, Anita. Anita, how are you doing today?
I am great. How are you, Jonathan?
Everything is fantastic now that we are here on the show.
Yes. I'm glad to be here. Thanks so much for inviting me.
It is our pleasure. It is my pleasure. Before we get into the questions today, we're going to be talking about eating disorders. We're going to be talking about DBT. Which is a super, super cool modality that I don't think we talk enough about. I'd love for the listeners to know a little bit more about you, the work you do, out of anywhere in the world. Like, why did you choose this space, this field of mental health?
You know, it's interesting. People have asked me that at different points in my career, and I always tried to find the answer or the answer that felt most true to me. And I always struggled with it. You know, how did I land in eating disorders or DBT for that matter? And the truth of it is that I think from a young age, I was always interested in people that didn't fit in. I was always interested in people that were mistreated. I was curious about it. I was bothered by it within my own family structure, within the school systems, and I was just always drawn to stories about people that um, were misunderstood and poorly treated. And so as I journeyed through, academics and school and figuring things out, I I was looking at eating disorders and schizophrenia, these two different areas. I was interested in both, and I happened to get a placement at the Toronto General Hospital working in their eating disorders program, and that really shaped where I went. But I wouldn't say that I'm defined by eating disorders per se so much as the pursuit of enhancing understanding and then thereafter treatments for people who are typically marginalized or misunderstood or who just constantly fall in the cracks, eating disorders being a large subgroup of those folks.
It's really interesting. And I want to talk about DBT, how it interacts with people who are slipping through the cracks. Like
Mm.
DB, um, it's interesting. Some of these topics that we cover, I'm curious about. This one, I'm curious, but also like DBT really saved my life at one point. Way before I started at EHN, I was going through a really rough time. My therapist, we were going through like a typical like anxiety CBT thing. Something had flipped in my own brain, and he was just like, "We're going to learn some new things today, Jonathan." And like I've taken that with me since then. So really excited to talk about that with you today.
Mhm.
Um, for the listeners who may not know, before we dive into the nitty gritty, like what is DBT?
DBT stands for Dialectical Behaviour Therapy, and it was a treatment that was developed in the late '80s, early '90s by a psychologist, Marsha Linehan, and she was particularly interested in suicide and self-injury, particularly in women who were considered treatment resistant, right? So again, I'm immediately drawn to that because I think, okay, who are people that are treatment resistant? What does that really mean? And her career took her on a journey where she developed a treatment for a misunderstood, marginalized population of people who were considered, untreatable. And her treatment, which balances, there are definitely change-based strategies in DBT. You know, you are helping people change, but they're balanced almost continuously with mindfulness-based practices, acceptance-based treatment, Buddhist philosophy. And so it makes up this very comprehensive and I think deeply compassionate and collaborative model that helps people who have been so hurt and sometimes deeply damaged by psychiatry, by labels, by being abandoned in lots of ways by care. It sort of reinvigorated trust that they could be understood and they could be treated differently. And lo and behold, isn't this amazing, Jonathan? When you treat people uh, in ways that they feel heard and understood, and as agents of change, not as crazy, not as manipulative, not as treatment resistant, they actually get better. They actually engage. And so, I mean, we would need a whole hour just to talk about what DBT is and the evidence base for it. But DBT has gone on to be one of the most highly sought after treatments, especially for people who have felt unheard and misunderstood, for sure.
So that's fantastic. Let's talk a bit about like the compassion and the mindfulness. Can you give an
Mm,
example of like
yeah.
we're in a session, like one that sticks out for me was we were a few sessions in. I learned some like of the base skills. I taken my fare of ice cold showers. And then
Yeah.
I'm in a session with my therapist, and like he said something, and I had become activated.
Mm,
And I'm a pretty like not characteristic of a good podcast host, but I'm generally more of a flat person, like
mm,
flat affect.
mhm.
And then he said something, start tearing, start going through it. And he's
Yeah.
like, "Hey, we're just gonna go through this together." And like we were talking through the activation.
Mhm.
When you say mindfulness, that's something that kind of comes up for me.
Yeah. Well, it's interesting because when people think about mindfulness, they immediately conjure up these images of having to sit, in the lotus position, with their palms facing upward, maybe on a dock, and they're in silence, right? Trying to just be in the moment. And that is a type of meditative practice. What we do in DBT is use mindfulness as a tool to observe and describe what is happening without judging it. And it can look very informal, like you just described, where I might sit with someone who I can see is having a response, a reaction, an emotion. And instead of avoiding it, say, let's notice without judging it, without putting labels on it. What are you experiencing right now? And let's try to make sense of it rather than throw it away, suppress it, or continue to light it on fire. So mindfulness and DBT can be both an informal practice like that, a moment by moment being together, and we also teach explicit skills both in individual sessions and in our skills groups where we have a whole module just on learning how to use mindfulness skills no matter where you are.
I feel like a roadblock that people would talk about is, well, like, how do I do that mindfulness at work or when
Yeah.
like my family is doing something like wild and I'm just like deeply upset in that moment. Like,
Yeah.
so there's like a big piece about like how to actually not just learn the skill, but like really how to apply it in a bunch
Yeah.
of different moments, how to prepare for those moments, all of those pieces.
Well, and this is why DBT doesn't just teach you mindfulness. It teaches a range of skills: emotion regulation, distress tolerance, interpersonal effectiveness, in a highly validating framework. And so nobody learns something new. Nobody goes into the fire without learning how to put out the fire. I mean, you would never do that. You have to practice. So we start where people are and we teach them general basics. How do I do it in the moment where you feel safe with me? How do we do it when things are quieter? But the idea in DBT is to help clients, to help people take what they're learning in the moment with me, let's say, out into their everyday life. So we will actively practice and we do skills coaching, right? So I don't, right? So a lot of people will get between session phone coaching. So someone could call me for coaching. They could be at a family event and say, I don't know what to do. I'm losing my mind. I feel really urgy. And I can go, wait a second, let's find our wise mind. And let's do a practice together. So a lot of times people need that between session help to practice in moments that are hard.
So we started off this conversation by talking about your passion for working with people who fall in the cracks, but the cracks look different for many different kinds of people. I'm wondering how do DBT skills specifically work and support people who are struggling with eating disorders?
Mhm. I first would say to respond is that I don't know if DBT or DBT skills are for everybody or for right. I think part of meeting with someone, whether they have an eating disorder or they have a personality disorder or they have whatever, is conceptualizing together like why are they struggling, what are the elements, and what treatment pathways make sense or are available. I'm more concerned with misaligned treatments, DBT or not. DBT to me happens to be one of the most um, flexible, comprehensive models I've ever trained in. So it tends, in my experience, to be a good fit for people that have problems with emotional expression, people that struggle with behaviors that they just can't sort of seem to change. I think DBT has been shown to be effective for such a wide range. But the beginning is first explaining what this is, how it works, what are the theories underneath it, just to even see if the person feels that makes sense to them. So that's the first part, because you can't just start teaching someone DBT skills and hope that they're just going to find them helpful, because so many people have had lousy experiences in treatment. So many people don't understand what the skills have to do with their eating disorder. I've talked to so many patients over the years who've been in hospitals and shuffled into DBT groups. And I'll say to them, well, why do you think you're in that group? And they go, I don't know. I was just told to come here. And I think that's not the spirit of it, right? I want people in a DBT group because they feel like it could make a difference in helping them get to a life that we call worth living, worth fighting for, worth recovering into. And the skills in DBT are a component of that journey. They're not the be all end all. But I also don't think it's sufficient. So many models are based on stopping people's symptoms. Like, well, let's take away the alcohol. Let's take away the hallucinations. Let's take away the purging. But rarely fill that void or that gap and how those symptoms were supporting that person. So the person is left in this kind of vacuum of like, great, I don't have these symptoms. I still feel like hell. And I think relapse is very high when that's the case. So DBT skills are part of, if we're going to do it differently, we need some other tools, right? And then I explain what the modules are to see if even that is of interest. And I link them to the specific person's experience. Right? It's very important for me to not make skills this generic, here, take this and you'll get better, right? It's, what does learning how to observe and describe emotion have to do with bulimia nervosa? That's where I go in the beginning.
I quite honestly don't know this myself. This might be a silly question, but when we think about eating disorders, we think of the behaviors that are associated with an eating disorder.
Mm-hmm.
And one of the concepts you brought up is you can't just teach skills and just take things away. That there's probably a higher chance of relapse or those behaviors coming back. What do you replace it with?
But part of it has to do with understanding another human being, right? So when I meet someone, I think about what are the functions of the various behaviors? Why do they drink? Why do they purge? Why are they restricting their eating? Right? What is happening? Because no behavior exists for no reason. And the research on eating disorders is also supportive of this, but eating disorders are not, I just don't want to gain weight. Like, that's the sort of social colloquial way people think about them. Eating disorders are neurometabolic illnesses tied to very specific biogenetic underpinnings, sensory disturbance, perceptual difficulties, metabolic changes or differences driving the way food is distributed, hormonal differences. Like, we're talking about significant illnesses that are then played out in a fat phobic diet culture world that praises the outcome of those biological processes. Right. So the first part when I'm working with people that have eating disorders is help them to understand that, these aren't just eat and everything gets better. Okay. The eating itself often soothes an unsettled biology. That's something that Cynthia Bulick talks about. It can soothe invalidating environments, right? It can do a lot for a person. So if I'm going to come in and try to say, let's build a life that's worth getting away from this eating disorder, knowing that you come by it naturally. Okay, you didn't pick it. Boy, we need to really map on how are we going to replace the sensory elements that restricting solves for you, right? So I may point to specific distress tolerance skills. I may weave in, different mindfulness skills, body-based somatic experiences. Like there's so many things, but you've got to really link it to understanding what eating disorders are. Otherwise, the skills just feel like you're kind of throwing paint at a wall sometimes, and people are like, that sounds like a great skill, don't know where to use it. Don't know how it applies to me.
I guess my next question, like, walk us through an example of what that might look like, where um, somebody may be in treatment or might be exploring treatment for an eating disorder.
Mm.
They're in their first few sessions. Let's go a little deeper into how you would support or start building supports around that person.
So the first part is um, I think collaborative case conceptualization is absolutely key. So I want that person to be able to sit at that table and first get to a place of I make sense. Because it's very hard to ask somebody to change their behavior when they feel like they're wrong or bad or there's something wrong with them. They can't just eat and they've internalized a lot of the stigma. Right? So the first part is to be able to go, of course I don't want to eat because if I eat this food, then I have to deal with the bloating that happens after. And I don't know how to do that. It makes me want to jump out of my skin. And then I have to deal with the guilt and the anxiety that I feel. I don't know how to do that. Then my urges to self-harm are going to go through the roof because now it's at night and there's no one around to help me. And so the first part is you make sense from a neurometabolic, sociocultural standpoint. So the first few sessions, and for a while sometimes, is helping people get to the place where they go, of course I just did that. Not I should continue to do that, but it makes sense that I get stuck here. It makes sense that this is hard for me. Okay. Then we do a lot of, maybe you've heard of these chain analyses or these missing link analyses where we are detectives, right? And I say, great, I want you to sit at that table where it's impossible for you to eat and everybody's now getting upset with you because you didn't eat enough and now it's stressful at home. And I want you to do a chain analysis, like a little mini, like put a magnifying glass on it. Like at what point did you say, I can't eat this? Because you sat down at the table, like, was that with the intention, I'm going to try? Like at what point did you feel like I'm done, I'm out? What emotions were there? What thoughts were there?
And is something that comes up, people might just sit down at that table and then whatever happens, happens. But there's like so
Something.
many little things that
Yeah.
are happening. And that's what that
Yeah.
chain analysis is. It's looking at
I
each.
love a chain. And chains get such a bad rap. Jonathan, I think so many people have gone through treatments where chain analysis has been used in a punishing way. Oh, you just had a symptom? There, do a chain. We're not going to talk to you until you do a chain. Oh my gosh. Chain analysis to me is one of the most empowering and collaborative interventions in the whole thing, where I get to sit, like imagine me and you, and it's like we're going to put on our headlamps. Okay. And I'm like, I want to know what happened that led to you purging your dinner. I want to know why you self-harmed at 9:00 at night. I really not because I think anything bad or wrong happened, because the devil's in the detail. And if we don't get the detail of the feelings, the thoughts, the actions, the urges, we're probably going to miss changing this for you. And I like how you're saying, Jonathan, like how nuanced and complicated things are for people. Humans are complicated. And if it was so easy to just fix an eating disorder, somebody would have swooped in earlier and done that, right? These are behaviors that serve massive functions in multiple domains. And until we really uncover it, I can throw a million interventions at you and none of them might work because the function still exists. Right? So first is I make sense and I use all the research to teach people why they make sense. Okay. Then it's let's get the detail. Let's do chain analysis. Let's come back together. Let's try to understand why it's so painful, why it's so hard. Then, and at the same time, people are starting to go to the skills groups, right? So while I'm doing this an individual session, ideally the person is also concurrently in one of our skills groups or in a DBT skills group. So now they're getting exposed once a week to these other concepts and ideas about how might someone handle a situation differently. And then they have phone coaching to put it all together. And you do that over and over again for at least 6 months, a year. And the changes are pretty phenomenal. Like it really is. Um, it's amazing to watch people who felt like nothing could ever change for them, get to that point where, oh my gosh, things have changed. And like the look on their face um, probably is what keeps me doing this.
Yeah, you have a great impact in that
It's
moment.
massive.
Yeah. So I guess for somebody who might have had their first session or their first 5 or first 10 sessions, you said, we typically start to see like those bigger changes maybe after 6 months. It takes time. These are,
Uh,
what are some of the like, as a therapist, you see those like really, really, really little like nuggets in the beginning
mhm.
where you're like, that's good that you did it that way. What are some of the little signs that you see on your end that somebody going through it might
So
not yet?
many. Well, especially when you're in a DBT environment, like people that come into DBT, uh, and this often gets missed in big studies because they don't measure this stuff usually. So the little things that I see that I pull out when I see them, it first of all, just even showing up to treatment for somebody who feels that treatment has been harmful, traumatic, the fact that they are still coming to talk to me, I'm curious about that, given that they, have good reasons to not trust anybody sometimes in the mental health field. So sometimes it's that. Sometimes it's a person's just honest about something. They tell me when they haven't told anybody else. They're like, "Well, I did purge. I did, my weight really wasn't this. It was that." Right? And I always say, I'm like, "Why are you telling me? Why? Why?" Because they trust. There's some trust there. They know that it's okay. There's no judgment. There's no punishment. So when people feel like they can be honest, um, and not fear consequences, that we've arrived to another level. Um, when just even sometimes when people just do the homework, like who wants to do homework? Oh, ugh. Especially if you've gone through multiple treatments, and you have to remember that a lot of times people that come to DBT have been in lots of other things, hospital care, all kinds of outpatient services, and a lot of times people are given homework and then no one ever checks it, right? Or the therapist forgets about it, or only looks at a small part of it. Like if I'm going to fill out a chain analysis for you, Jonathan, I expect you're going to look at that thing, right? Because that's going to reinforce me. So even that corrective experience of like you did the diary card, I really respect that. Thank you so much for doing that. You filled out the diary. You practiced the skill. Stop, because these are folks that are so hurt and so misunderstood. Why would they be vulnerable with anybody? Because the risks are high for them. They don't really know me yet. They don't know if I'm going to approach it like everybody else does. And look at the flaw, look at what right? So it's those like little baby steps, if you will, like little steps, and then you just see more and more of it. People willing to try something different, people using phone coaching, um, people talking in group. The people who said, we had a client recently, she says, she graduated from her 6 months. She says, I was very anti-group. She argued with her therapist. I'm not going to group. I'm not a group person. I don't do group, right? At the end of 6 months, she was in tears. She says, this has been the most corrective experience that I've ever had. And she was sad to like end the treatment. And it's all of these things that go on. But I believe the conditions are there for people to do it. That's what DBT does. Anybody can pick up a skills book and read it. Okay. But to teach it and coach it and live it and model it and recognize it in another person and make them see that it's possible, that environment is contagious in my view. It makes me sad that people don't get to feel that more often in their everyday lives. How amazing each person is,
All
how
that.
skillful they are and can continue to be, right?
Yeah.
Uh,
And there's a lot there. But one thing that really stuck out to me is just like, even if you just looked at the behavioral component of it, like somebody does their homework, absolutely, as like a clinician, like that's somebody like sharing something in some way. That's a party. That's like the
Mhm.
big moment. That's where like you get to step in and like, wow, you actually like went and did the thing.
I love that when I see that because I know how hard it is. Not because I wanna be some, "Good job, you did your homework," because it's what it means that you thought about it when we weren't in the space together, that you put your time into it, that you're engaging in something I believe in could help you, even if you don't always believe it yourself, that you're presenting it to me, that you're like, I can show up all day long with that stuff for people. Like, I love when people trust me or the treatment enough to do that. That is what I'm reinforcing when I see it. Yeah.
So I have another question, and it's kind of a flip side. We're talking about the relationship that like you or like another clinician
Mhm.
have directly with a client. It's very there's structure, there's a lot of intent, there's a lot of things and
Mhm.
experience that you bring to that. But often, and probably most of the time, that individual has a lot of other people in their life, uh,
Mm.
family, a friend, or a loved one who doesn't necessarily know or understand
No,
everything like DBT, for example, brings to the table. Um,
no.
what are the skills? What's the work that the people around the person need
Oh,
to
oh
show?
gosh. So that's the norm. I would argue that most people go back to environments that are quite invalidating and not even intentionally. It's just people don't understand why people suffer or continue to do what they do. They're just not aware. And so it's easy to judge what we don't understand. In an ideal world, anybody that is living with someone else, like in an ideal world, I would love for them to come and learn caregiver DBT, to do some kind of, I love someone with an eating disorder, so I'm going to understand this. I love someone with suicide and self injury because that is so helpful. Um, and it's really hard because a lot of families don't have extra time or don't have extra money. There are some great nonprofits that offer this kind of stuff. And so it gets hard. It gets hard. And the reality is, Jonathan, that many loved ones just can't. So you often have, especially as adults, you often have adult clients who live in environments that are invalidating. And sometimes you can't just get the family in. So I do a couple of things. One would be, and maybe I'm not answering your question. One would be, how can I help my client either influence their family, their loved ones? What could they say skillfully? Hey, Jonathan, I know you are swamped. It would mean so much to me if you would take this course. I think it would be so much better for our relationship if you were learning this with me. Are you open to that? Like, you'd be surprised sometimes when people just ask skillfully, people will do stuff that you want. And sometimes I have to help clients recover from invalidation. Like, how do you minimize being in those environments? How do you recover? Um, but I do different DBT caregiver groups. Like, I do a general one, and then I do one for eating disorder, people that love someone with an eating disorder plus plus. It's just caregivers, and it's one of my favorite groups of all time. To have, it's usually parents, and they really benefit from learning what dialectics is as a way of being in the world. They really benefit from learning their own mindfulness skills. And I often teach parents, I'm like, if you're at the table and you're not in wise mind, you may go do a distress tolerance skill. Don't try to help your kid eat dinner when you're in emotion mind. That's just a recipe for, fireworks. So I teach parents how to understand their own internal triggers so they can be the most skillful. Right? It's kind of like, I imagine it's like training like a flight attendant, right? Right? Everyone on the plane's nervous, and what do? You look at the flight attendant. Okay, so the flight attendant has been through this 17 times. They know, they're like, this is fine. This is just turbulence. It's okay, everybody. I'm going to still bring you the coffee. Okay, so you teach parents how to be in turbulent situations without panicking, and to know when it's actually a crisis and they need to sit down and buckle up. But most parents never get, and I mean, not just of little kids, I mean, across the spectrum. I have a lot of patients who are in their 30s and 40s who are still very reliant on their families. And the families have had none of that support. They might learn how to feed a child. They may learn how to do certain things, but not the kind of stuff that DBT gives to a family.
Really interesting. I love the flight attendant analogy. Usually people would like there's kind of the oxygen mask one, but I like yours. That's great.
Okay.
Um, I guess like when you're the person going through it, you have one experience of supper time and sitting down with your family and like having that kind of distress and that kind of
Mhm.
those kind of thoughts running through your mind. But as a family, like as a parent, dinner's also been distressing for you for a long time, and you
Yeah.
probably have a similar, in a way, kind of
Mhm.
shut off when you sit down at the supper table. Something's going to happen, and then suddenly
So
supper's over,
stressful.
and the cycle is there.
Yeah. And so you're right. And both parties, in DBT, we talk about transactions, interactions. So you have this person, let's say, with an eating disorder who's facing one of the hardest exposures of the day to eat a meal, let's say. And so they're in a hard place. And now you've got a parent who maybe has been working all day, is tired, maybe has other children, has a migraine, and they're just trying to get to bed, like, and there's a history of things not going well. And now they have to sit again at a table. So you've got two emotion minded people sitting at a table trying to do a really hard exposure, right? If that was a therapist and client, if that was you, Jonathan, with a client, I'd be like, Jonathan, get out. You're too emotional. You can't do the exposure, right? But families don't have that luxury. And this is why surgeons don't operate on their own family, because it's hard to stay neutral when you love someone so damn much and you're scared. And so it is hard, but that's the power of when you can treat the family, the outcomes are so much better. And it's hard. It's a lot of time, sometimes money, energy for a whole family. So it's tricky.
Yeah. When I started working here at EHN, we have this facility in Alberta called EHN Sandstone Recovery, and one of, and before this, I actually worked as a social worker for quite a long time, and I was reading through like the list of things that they do, and I'm like, okay, interesting, interesting, but they have family supper time, and I'm like I
I'm gonna go do that.
that sounds nice, but why? Like, what's going on? Um, and it's so interesting, and I really appreciate that. That there's both sides, and that that's a big
Yeah.
piece of what you do.
Well, and the thing is too that when you can't treat the system that a person lives in, and you don't teach people some of these things, invalidation, judgment, and making assumptions run rampant. Right. So when if you're a parent, you don't really understand that eating disorders are neurometabolic. What does that even mean? A lot of times the frustrated family member says, "Would you just eat? Like, what is wrong with you?" Like, there's that exacerbation, that sort of, right? Rather than going, okay, this person probably isn't eating because they don't know how to manage the sensory issues, the emotional dysregulation, or whatever it is. That's hard on me. Maybe I'm going to try one, two, or three skills. Right? We are more gentle with one another. We are more validating, even when we don't like things, when we understand the complexity. Right? Like, so if you have a family member with cancer and they say, I'm too nauseous, I'm not eating, no one goes, would you just eat? Like, could enough already?
What about the green beans?
Right? About, can you, right? Like,
Yeah.
but there's something about eating disorders where there is that communication that happens. And to me, that misses that this isn't just someone sitting there going, I'm just not going to eat. This is someone who's actually not eating to cope with quite a large constellation of stuff that nobody can see. right? And then the thing that I find really hard on families and on clients is that everyone wants to focus on the act of, okay, let's get you to just eat this soup, eat this dinner, eat this, and then you're good. At least we did that one meal. But it's like throwing like a stone in the lake. Like, yeah, great, they had the meal. Now the ripple effects are going to go on for that person for hours. Right now, they feel swollen, they feel bloated, they feel suicidal, they feel like tearing their skin off. They don't know how to manage. But that's usually when people back off because the meal's done. Like, okay, well, I'll see you at the evening snack, and the person's sitting there going, I can't even breathe anymore. And so a lot is missed or misunderstood for people that are struggling, for eating disorders, but I think for lots of things in mental health. Right? And I think DBT provides a framework and a language for making sense of what is usually buried, right? And like dusting that off and going, wait a minute, you're not crazy, you're not deceptive. You actually have all these things that you're trying to manage.
Amazing. Anita, this was fantastic. I know probably chat about, uh, I mean, this is your everyday, you chat about it for like hours and hours and hours. So I really appreciate you sharing your time and your expertise with us and our listeners. For people who are looking to learn more from you about DBT, about eating disorders, and about all the other wonderful things you do, where can they find you?
You can find me probably on Instagram is the best way. I'm pretty old school, everybody. I have like an at Dr. Anita Federici. I don't even know my handle. So, I
We'll
try to
throw it in the
stay.
show notes.
You'll put it in the notes. Okay. So on Instagram, I'm on LinkedIn and those places, but I try to use Instagram as a way of communicating what I'm learning or to translate like things I pick up like at conferences or in journals. I try to like share those with people, but I love staying in touch. Because you're just always learning.
Anita, it's been a pleasure. Thank you so much, and can't wait to learn from you more next time.